Hi, this is Sarah Gilly. I'm coming to you with the presentation for my leadership project for Palm Beach State, the BSN program for the Leadership in Management and Professional Nursing this summer. Some credits are due for the help and supervision of this project. My preceptor, Arwin Naval, facility for my project, JFK Medical Center, main campus in Atlantis, Florida, and Dr. Carol Clark, my professor for the course. This project details my leadership project for the summer semester. I chose to feature a project about falls in the hospital. Falls in the hospital are a major problem on the unit where I work. We needed a revamping of our fall prevention program. In order to prevent falls, we must have a strong fall prevention program with updated policies. Part of this new program includes the development and implementation of a fall safety contract. A fall is defined by the Joint Commission as an unplanned descent to the floor with or without injury to the patient. As a post-operative unit, patients need to be mobilized as much as possible. Falls are the #1 cause of injury in the hospital. My unit had 33 falls in 2015, with at least 2 with significant injury. In an article by Zhang and Zin in 2015, they stated that injurious falls in the hospital are the most prevalent adverse events in the hospital. Hospitalized patients have a greater fall risk than the average general population. After a fall, the patient stays an average of 6 extra days longer, and the hospital stay costs $13,000 more. Medicare does not cover these preventable events and additional costs, and it falls back on the facility. Zhang and Yin felt that if the patients were engaged on their own safety and fall prevention, that this would reduce falls altogether. This is where the patient safety agreement comes in. The patient is engaged in their own care and safety and is taught that we are serious about their safety and agree not to get out of bed or try to mobilize alone. This will prevent falls by the patient getting involved. This provides for more patient-centered care as well. In this situation, the clinical problem we are reviewing is the lack of formal fall prevention program policies in place. Falls are a major problem in acute care facilities, and with a standard set of fall prevention plans, we will all be on the same page. With the many scattered fall prevention tactics we have now, we needed to nail down a set of standards and initiate the implementation of the Fall Safety Agreement. According to Cox, Thomas Hawkins, Padrillo, DeGennaro, Cadmus, and Martinez, 2014, who wrote Factors Associated with Falls in Hospitalized Adult Patients, they wanted to identify which factors make the patient the highest risk for falls and to be aware of them. Some of the most concerning factors associated with the fall are patients admitted with neuromusculoskeletal disease, such as a stroke, advanced age, usually the evening or overnight shift, and the patient being administered multiple narcotics and sedatives. Patients who were prescribed and administered narcotics were 16 times more likely to fall than taking no narcotics. A different article by Coyle and Mazaleski called Initiating and Sustaining a Fall Prevention Program felt that their program needed more intensive help with preventing falls. So they took an interdisciplinary approach and got physical therapy and pharmacy involved with screening patients for risk for falls based on mobility and what medications were on their list. Hoke and Garasino wrote Beyond Socks, Signs, and Alarms in 2016. Their method was accountability-based. They decided to make an accountability-based fall prevention program where a staff member had to take responsibility of a fall. Each time a nurse's patient fell, they were responsible for sending an email to every staff member on the unit. In this email, they provided the situation surrounding the fall, what they felt caused the patient to fall, the patient's opinion on what caused them to fall, and how it could have been prevented. I think the accountability for the staff members is just embarrassing enough to the staff that they will not let it happen again. Quigley, Barnett, Bulat, and Friedman wrote Reducing Falls and Fall-Related Injuries on Medical Surgical Units in 2016. They wrote up an extensive new fall prevention program based on 4 phases that altogether included writing a new manual, taking orthostatic blood pressures, delirium assessments, hip protectors, floor mats, and engaging patients in education using the Teach Back method. Zhang and Yin wrote Patient Engagement in Hospital Fall Prevention in 2015. They calculated how much extra time the average patient who fell in the hospital had to stay and the additional cost incurred. After a fall, the patient stays an average of 6 extra days longer, and the hospital stay costs $13,000 more. This study is crucial because Medicare doesn't cover the costs that are due to a patient falling in the hospital and must be absorbed by the facility. Also, any patient that has to stay at least 6 days longer is a huge hit to our average length of stay. In 2015, my unit had 33 falls, some with a substantial injury, including a patient who had to go back to surgery for repair of a fracture caused by a fall. So far in 2016, we have had 14 falls, one with injury. A general goal for my leadership project is to reduce the number of falls on my floor by instructing patients to call for assistance before they try to exit the bed alone. Falls are an issue in every hospital, and the Fall Safety Agreement is a low-cost initiative that can improve patient outcomes and reduce the number of falls. The intervention was applied by the staff nurses having patients sign the agreements who are alert and oriented. They would bring the paper in upon admission and have the patient sign after explaining it thoroughly. They then photocopy it and place one copy in the chart and the other copy on the wall in the patient's room to remind them of our agreement. For this initiative, I have used the Chief Nursing Officer to review the project, my director to help me educate the staff, many floor nurses for championing the effort and having the patient sign, the case manager for explaining the agreement and the preoperative class, and my preceptor for helping me guide along the way. I will collect the data of the quantity of contracts signed by the patients compared with the number of falls. In 2015, my unit experienced 33 patient falls. We will use this number divided by 12 months to be 12.75 falls per month. We will apply the new fall interventions for 1 month and calculate the total number of falls in the time period and compare them with the 2.75 to evaluate if the program is a success. This month so far, we have had an unusually high census for the summer. Usually our census is low during the summer because of the lack of snowbirds, but this year is different. We have already had 3 falls this month so far. This doesn't mean I would consider this a failure, but more time is needed to pilot the study to be judged fairly. I would recommend for a future study that there be at least a year of pilot time to decide if it is a success. It can be compared with the previous year to decide if it is a success. I would also include the PCAs, patient care assistants, involved with the new fall precautions too. They have a lot of direct bedside connection with our patients, and they need to be more educated about fall prevention strategies. For my project, I initiated a fall safety contract on my unit. This initiative has the patient agree they will call before trying to get out of bed alone because this is when the patient falls occur. I have not yet found it a success, but feel the study needs more time. I think falls are a continuing problem in acute care facilities, including our unit. By educating staff and nurses on the dangers of falls and how to prevent them, we can decrease the number of falls on the unit. I have provided my references used for the presentation. Thank you for viewing my presentation on the leadership project for summer semester 2016. Any questions regarding the project can be emailed to me personally.